Yeah, we can start.
Good morning, everybody. Today's my topic is IOL calculation and surgical technique in pediatric cataract. Surgical technique in pediatric cataract is in next class. In 1992, WHO estimated that there are 1.5 million children with blindness in world, of which 1 million live in Asia. This figure will increase 2 million by 2020. Almost 12% of childhood blindness caused by cataract. Commonest cause of pediatric cataract in India are idiopathic 30 to 50%, hereditary 7 to 20%, congenital rubella syndrome is 10 to 20%. Secondary to metabolic disease is 5 to 10%, and traumatic is 10%. Starting with anatomical consideration, although the pediatric eye is small, it is not an adult eye. It has its own anatomical and physiological characteristic like short axial length, steeper cornea with high keratometry value, and smaller AC depth. So the difficulty that are encountered with the implantation of IOL in children include the selection of appropriate lens material, size, design, and most important, accurate IOL power calculation. The axial length at birth is 16.8 mm. After 1 year, 20 mm. So most of the changes in axial length occur in first 2 year of life, which increase 0.62 mm per month in first 6 months, and 0.19 mm per month from 6 to 18 months. So keratometry value at neonate is 48.4 diopter plus or minus 1.7 diopter. At 1 month, 45 diopter plus or minus 2.3 diopter, and at 36 month it is like at adult keratometry. The lens power changes from the 34.4 diopter at birth to 18 diopter in adulthood. It drops 10 diopter in first year of life, then the 3 to 4 diopter from the 2 to 10 years. The diameter of the lens is at birth 6 mm, and at 16 year 9.3 mm. So the capsular diameter at birth is 7 mm, at 16 year 0.5 mm. So now, what is the challenges in pediatric cataract? IOL power calculation is children is a unique challenge, not only because of the pediatric eye is not a small adult eye, but also because of the measuring challenging and changing the refraction which take place more rapid at younger age. Eye with congenital cataract may have greater anatomical variation. The idea of implanting a fixed power IOL into the eye, which is still growing, makes it difficult to choose the perfect or an optical IOL power for the children. We could divide the IOL power calculation and final decision deciding on the power calculation in children into the broad category into three category: equipment needed, prediction error, and formula use and under correction in IOL power. So now equipment needed is a scan under anesthesia, especially in children who may uncooperative or delayed developmental milestone. A handheld keratometry is a must while calculating the keratometry in children. If keratometer is absent, so reading is around 43 to 44 diopter has been used, but we present the reader to avoid it as much as possible. The Kobasi et al. Handheld keratometry device provide excellent repeatability and comparability of the corneal power and corneal astigmatism. So we can use a scan. The explanation is conventional. It is used by accurate with trained biometries. It is corneal compression. So contact applanation is error maybe one diopter around, and immersion it is more accurate. No risk of error from the excess pressure applied because of the coupling fluid fill the scleral cup. The immersion A scan should be always be preferred over the contact A scan under the anesthesia. So multiple readings should be taken. The reading which higher anterior chamber depth should be included in the final measurement. The uprolling of the eye and bulge phenomena should be avoided during the immersion. The sterility should be maintained. The predictor error and the formula use. The multiple study are now available which have the compare all formula for the predictive value of the IOL power calculation. Starting from the Andrew et al. Who reported all the formula are slightly less accurate in short axial length. In their study, OFRQ formula had a lower error and SRK2 had a higher error. Now, Indian studies, Kekunaya et al. Reported SRK2 as the least predictive error, where the Vasavda et al. Reported SRKT and Holiday 2 at the least predictive error. In basis of the axial length, Holiday 2 formula is considered to be most accurate for eye with axial length between 22 to 26 mm. The OFRQ formula is considered to be most accurate for shorter eye, less than 24.5 mm, and the SRKT formula is considered optimal for the longer eye. Now, recently in May 2022, the Barrett Universal 2 formula versus the SRK2, that's found the Barrett 2 formula seem to be good result in younger age group with flat cornea and the axial length in between 21 to 24 mm. The undercorrection of IOL power as the eye is rapidly growing more. So when the children is younger, the and undercorrection is a must. So the child does end up having a high myopic shift in the later year. The rate of the axial length growth is higher at younger age, and even in pseudophakic child is more rapid unilateral cases compared to the bilateral cases. Multiple ways and method have been presented and published to undercorrect the IOL power in children. It is depending upon the age. A undercorrection of 20% selected for a age group of children less than 2 years of age, with higher undercorrection when the child is closer to the birth. It is Trivedi et al. At 2006. It is the first year undercorrection is 12 to 7 diopter. In 1 to 2 year, it around plus 6 diopter, and this is 7 year 1.5 diopter, and 14 year is plano. But it is not used nowadays. Most probably we can use under 1 year no IOL implantation. The children makes of phakic after 1 to 2 year 30% reduction around 5 to 6 diopter under correction. 2 to 3 year the 20% is under correction 3 to 4 diopter, and above 5 to in between 5 to 7 year we can use emetropic eye. The rule of seven, the NAD et al. Suggests the rule of seven to undercorrect the IOL power in the children. The example is the age of children is 3 years. The once the we subtract 7 minus 3 is equal to 4. So we get 4 diopter as the amount of undercorrection to be done for the particular child. But the Satdev et al. Used the NAD rule of undercorrection and reported to lower undercorrection for the children under 2 year of age, as their age group had higher hypermetropic than we expected as per the rule of seven. The second is depending upon the unilaterality. Vasavda et al. large rate of the axial length in unilateral cataract when compared to bilateral cataract. Fan et al., which pointed toward the same, a higher expected myopic shift in the children with unilateral cataract. So we can postoperatively we can anisometric not more than 2.5 diopter. Third is depending upon the axial length. Now we will some two example upon the axial length. One children is axial length is 22 mm. The age is 3, so under correction is around 20%. So IOL power in a scan immersion is 20.5 pounds. What is the power is around 16.5 diopter. It is axial length around 22 mm. And the second case is 19 mm. It is hypermetropic eye, smaller eye. So power is around 28.5 diopter, and after under correction of 20%, IOL power is 22.5 diopter. So the under correction on the basis of the percentage, which is difference of the axial length. One
My
paper.
previous slide, Ekbar, again repeat the slide. What are you showing here?
Sir, depending upon the axial length, power may be difference from original power, sir.
No, but here you have not changed anything. Whether it is axial length of 22 or axial length of 19, you have done 20% under correction only.
Yes, sir. Yes. It
So,
is basic.
so, so the
Maybe.
basis of percentage is not axial length, no, it is age.
Yes, sir. Yes, it's.
Okay, that is what you are showing here.
Yes, sir.
Okay, fine.
One paper presented out finding of the AIOC 2016, which clearly demonstrated the larger eye would be grow at a higher rate of the axial length compared to the smaller eye. We recommended the preoperative excellence should be considered, and the total under correction should be increase or decrease depending on whether the eye is myopic or hypermetropic before the surgery. So 17 mm excellence we almost IOL power is 28 diopter, and there is a adult eye like 21 mm. The normal IOL power is 22 diopters we can put depending upon the excellence. The presence of amblyopia. The treatment of amblyopia is easier if the power of glasses and anisometropia is low post-operatively. Although the amblyopic eye are more prone to the axial length, and this myopic shift could be tackled easier with refractive surgery at a later date compared to the hypermetropia. The parents and sibling refractive error. It has been noted that if both parents are myopic, 30 to 40% of their children become myopic. Where if one parent is myopic, then 20 to 25% of their myopic child. If neither of parents is myopic, fewer than 10% of their children will become myopic. So the history of parents is more important in OPD. The IOL power for the secondary IOL implantation in aphakic. We can put PCIOL or sulcus basis IOL after 2 years. The vast majority of children undergoing secondary IOL implantation had primary posterior capsulotomy and anterior vitrectomy. If adequate peripheral capsular support is present, the IOL is placed into the reopened capsular bag or in the ciliary sulcus. The axial length could be calculated using a scan in the phakic mode. And the Senoy et al. Reported good outcome with sulcus three-piece IOL three-piece IOL into the sulcus. The mean predictive error is 1.65 diopter, and they also be found the SRK2 given more favorable refractive outcomes. The IOL power, it depending upon the iris fixation. The iris glow IOL have been higher predictive error. The Bhandari et al. Reported as a series of 363 pediatric eye at a post-operative outcome is 2.5 to 4.5 diopter error. The available online calculator, it can be used for IOL power calculation in both primary and secondary IOL implantation. A constant of the intent IOL to be implanted, axial length and keratometry value. The desired post-operative refraction can be entered to be the optimal IOL power value. How much the under correction is, it is most important. Once the amount of under correction is decided, it is important to understand that that is not to be directly subtract from the amount of the IOL that has been calculated. Now one example is there. So one in right eye axial length is 22.32 and left eye is 22.22. So the immersion S can we make right eye 22 and left eye 23 power. If same patient, we can expect refractive power under correction 4 diopter. So we can not directly from the subtract 22. We can post operative refraction is 4 diopter. So the in right eye 16 diopter. In right eye 16 diopter and left eye 17 diopter is outcome. Otherwise, we can put 18 diopter or 19 diopter. We can post-operative surprise is maybe 2 diopter.
No, go back to the previous slide. What is the reference for this?
Sir, one AIOC calculation, the Jitendra Jethani, sir.
Okay. So here basically see there are two ways. One, as you said, we do under correction of the IL power.
Yes.
Okay. So when we say 20% reduction, that is 20% reduction in IL power.
Yes.
Fine. And second is target of hyperopia. So those are two different formulae. So one formula says that, for example, say at the age of 3 years, we are targeting say +4 diopter hyperopia.
Yes.
Okay, in that case, this right side which you have shown is okay. Where in the calculator only you target +4 and then accordingly you calculate the IL power.
Yes.
Okay, but if you are just saying that there will be 10% under correction, that is 10% under correction of the IL power only.
Yes.
Okay, not related to the hyperopia. Okay, so different formula are there. Okay, so we have to choose which one we want to do. So generally we go ahead with the under correction of the IL power.
Yes.
Okay.
Okay. Sir, same calculation is basic upon the this myopic patient, sir.
Yeah, any patient. See, basically there are two types of formula. One is where you are calculating like this much hypermetropia we have to keep after the surgery.
Yes.
In that case, this we can use this method where you put the target as say, for example, +4 hyperopia is what you are going to plan. That rule of 7 is there, na? 7
Yes.
minus 3. So 4
Seven.
diopter hyperopia at the age of 3 years. That is what is planned. Then in Barrett calculator, you can put the target as +4 and then you can calculate the IL power. Okay. But
Yes.
if you are using the formula, the other formula, which is less than 2 years, we are doing 20 to 30% under correction. 2 to 3 years, we are doing 10 to 20, right?
Yes.
About 3 years, 3 to 5 years, 10%. And then above that, no wonder. Then we have to just subtract the percentage only. We don't have to look at the hyperopia.
Yes. Yes.
Okay, got it.
Yes.
So both methods can be used and both are not accurate method because in pediatric cases, we know that standard deviation of the error will be quite high.
Yes.
Okay, but if you are using one method for one eye, use the same method for the other eye also. Otherwise, there might be anisometropy.
Yes.
Okay,
Yes.
ठीक.
Sir, finish this part is I will.
Yeah. So basically, we have to first decide whether we want to put IOL or not. So generally, for bilateral cataracts, up to 1 year of age, and even up to 2 year of age, we may not put IOL. Okay, but nowadays, of course, between 1 to 2 years, some surgeons are putting bilateral IOLs. Okay, up to 2 years, doing posterior capsulorhexis and antivitrectomy is must. Okay, up to 5 6 years, PCCC is must. Antivitrectomy is optional.
Yes.
For secondary IOL, generally we wait for 2 to 3 years because, as you have mentioned in the first slide, that slide is very important. So the slide where the growth, how it is achieved is shown. So it is important that see first 3 years, the change in the axial length and keratometry is at very rapid uh, rate, and after 3 years, it reduces. The change keeps on continuing, but the rate of change is quite reduced. So
Yes.
generally after that's why after 2 years we can think of doing a secondary IL where the IL power calculation will be more accurate because now the axial length reaches almost near the adult, though not fully adult, but maybe within 1 millimeter or 1.5 millimeter of the adult axial length. So that is when we can put.
Yes.
In unilateral cataract, generally we tend to put IOL much earlier. Say even 6 months, 9 months of age, we can put the IOL if the eye size is okay. So if the eye size is very small, for example, say the axial length is less than 18 or 17, then it may be very difficult to put the IOL and better not to put the IOL in such cases. But if the bag is adequate size, then we can put the IOL in unilateral cataracts. And main issue is that if we do the undercorrection formula, use the undercorrection formula for unilateral cataract, what happens is that there is quite large anisometropia which is there. So if patient has say +6 diopter anisometropia, patient is going to have dense amblyopia. So in such cases, we do not do the complete undercorrection. We just do little bit of undercorrection, and we expect that patient is will be more myopic later. But that we can correct by various methods like putting a sulcus IOL correction IOL later or doing a corneal refractive procedure. Okay. So unilateral cataract generally we don't do or we do very little undercorrection.
Yes.
Okay. Any
Yes.
doubts from the students?
No, sir.
What is this alpine ski house on your slide?
Sir, it is.
Read yourself. Do not just copy paste the presentations because
No,
you
sir.
have to
It is
understand.
presenting PowerPoint, sir, already in the
Okay,
slide,
fine.
sir. Not.
So that's fine. Okay. So basically, you have to understand the subject properly and then present. So overall, it is good. You can further, read about this.
Yes.
Pediatric cataract, as such, there will be a lot of predictive errors which are there. That's why none of the formulas work very well. So in
Yes.
our practice, we generally use the SRK T formula for these eyes. And keratometry, we generally take 43 or 44 as standard when we are planning to implant the IOL. Because as you have mentioned, that keratometric changes in the first 3 years of life are also very rapid. So if we take the present keratometry, for example, say it is 46, and we take it, it might reduce to 43 in next couple of years. So again, there will be IL under correction will be there. Okay.
Yes.
Okay. Okay. Any questions from the students?
No, sir.
Okay. So next class we'll talk about the surgical technique also.
Yes.
Okay. Yeah.
Yes. Thank you, sir.